Okay, hello. Hi, Dr. Pratik
Hi.
Choudhary. Nice to meet you. My name is Dr. Asma Jassim. I am a consultant pediatric endocrinologist and the Secretary General of the Emirates Diabetes and Endocrine Society. Happy to have you here in the American conference, and I would like you to introduce yourself to our audience and viewers on the YouTube, please.
Thank you. So I'm Professor Pratik Choudhary. I'm an adult diabetologist, and I say diabetologist because I don't do any endocrinology. I only do diabetes, and I'm a clinical academic, which means I spend half of my time doing research, mainly in hypoglycemia and in diabetes technology. And the rest of the half of my time I see patients.
Okay. So I think we will be maybe talking about hypoglycemia, which is also a very close topic to my heart, being a pediatric endocrinologist. So just to start with, doctor, let me just start. When we generally define hypoglycemia, how do we define hypoglycemia?
It's so tricky, actually, because there's lots of different definitions. And when I speak to colleagues, doctors, but also patients, and you say the word hypo, the image that comes in their mind is of someone who's unconscious, needing help.
Yes.
But in today's world, where we work in Western Europe, I work in the UK, 95% of our type 1s have a sensor.
Yes.
And so for them, hypoglycemia really is their sensor beeping.
Yes.
Buzzing at a glucose of 70 or 3.9 millimoles per deciliter.
Yes.
So when we say the word hypoglycemia, actually we need to, I think, be clear what we're talking about.
Yes.
Are we talking about a technology detected event where a machine has beeped?
Yes.
Are we talking about a symptomatic hypo where I feel some symptoms and I take some treatment?
Yes.
Or am I talking about this severe hypo which we want to avoid and which of course is very dangerous? So I think we need to be clear what we're talking about.
Yes. So I would like to know, like, in spite of such advances in therapies, why do hypoglycemia remains such a common entity?
So the reality is that the rate of severe hypoglycemia, the one where people are unconscious or need help to support, has reduced by more than 50% in the last 5 years.
Okay.
With the advent of better education, advent of better insulins, advent of more technology.
Yes.
But that severe hypoglycemia has gone down.
Yes.
But what's gone up, because we're using more sensors, people are monitoring glucose more frequently, is technology-detected hypoglycemia.
Yes.
So when we say it's not been solved, and of course you're well aware, the physiological reasons why we get hypoglycemia are always there. In someone with type 1 diabetes, you have excess insulin. We don't have glucagon.
Yes.
People mismatch for food or for exercise.
Yes.
And so on a day-to-day basis, those are the reasons why we get the hypo.
Yes.
But at the moment, we're getting much milder hypoglycemia than what we used to get 20 years ago.
Yes. So in the other way, that we could say that this is we managed to reduce the severe hypoglycemia because of the advance in the era of technology. But on the other hand, there are common pitfalls in the technology, which we. So in that case, I would like to know, what's the most, like, the things that we advise, or you advise your patients when you start them on sensors, especially regarding the hypoglycemia?
Thank you. That's a really good question. And I must, of course, caveat that answer by the fact that I'm an adult endocrinologist. So I do not deal with the people that you deal with.
Yes.
There's very small children who can't speak or can't express that they're low, right?
Yes.
And that's a different story.
Yes.
But for most of my adult patients, I use a very simple example to explain different levels of hypoglycemia. I'll be talking about that in my lecture later on this afternoon.
Okay.
And I call the example, so I would say to someone, like if I'm speaking to yourself, I'd say, in your car you might have a parking sensor.
Yes.
And as you reverse into the space, it beeps.
Yes.
And when the first time it beeps, that is like your sugar is 70. You're not in danger, but look around, be careful.
Yes.
If you stop there, you'll never be able to park.
Yeah.
If you're so scared of 70 that you'll never go below it, your sugar will always remain high. 70 is just a warning sign that you might be in an area of danger. Be careful, look around.
Yes.
If you're, as you reverse into your parking space and the beep goes beep, 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 that's when you want to stop.
Yes.
That is 55.
Yes.
Because we know that all the harms of hypoglycemia that we've seen happen at below 55.
Yes.
Right?
Yes.
And then, if you hit the car behind, it goes beep, and it's a problem. That's like 40.
Yes.
We don't want you to be there.
Yes.
So I want to make this, so when you get But people are scared of hypoglycemia when they hear that first beep of 70.
Yes.
They think the same, their emotional response is I've hit the car behind and I've died in the crash.
Yes.
So I want to separate out, okay, there's action to be taken between 70 and 55.
Yes.
Take some carbohydrates, take some dates, take whatever you want to.
Yeah.
But that's not dangerous.
Yes.
Dangerous is getting below 50
Yes.
for half an hour, 40
Yes.
minutes. So I want to separate the inconvenience
Yeah.
and unpleasantness, which is important,
Yes.
from the danger and risk.
Yes.
And I think in a lot of the education around hypoglycemia, we're not good at doing that.
Yes, yeah. And this comes to me in my mind another question, because what are the consequences of over-treatment? That's the issue, because the patient, when they do not know how to differentiate or the actions taken, it might end in the other end where you over-treat. So if you can talk about the over-treatment of hypoglycemia.
Absolutely. So now with sensors, we see this so commonly, right? That people will see the sugar dropping towards, so people often are not educated on what the arrows mean when they're wearing a sensor, and they will see a glucose of 100 or 120 with a down arrow.
Yes.
And actually it means that you're dropping by 1 milligram per deciliter per minute. So that means if you're 100, you've got more than 30 minutes before you're going to be hypo.
Yes.
But the panic comes in because the education isn't there.
Yes. Yes.
And people will overtreat. So I often say when you're treating hypos, you need to think about like you're in the middle lane of the motorway, in the highway.
Yes.
If
Yes.
you're almost going to crash off the motorway, you're going to turn the steering wheel quite
Yes.
strong.
Yes.
That is 15 grams of glucose.
Yes. Yes.
That is a half a glass of orange juice. That is 4 Haribos or maybe
Yes.
4 dates.
Exactly.
And so that's if you're about to crash, which
Yes.
means your sugar is below 70.
Yes. Yes.
But if you're in the middle lane, your sugar is 100, 110,
Yes.
and it's drifting a bit. You don't need to take the full correction. 1 date, 1 Haribo, 5
Yes.
grams
Yes.
is enough to just straighten the car and keep you in the middle lane.
Yes. Yes.
So that's the example we use in our clinic to kind of differentiate what you need to do if your sugar is dropping,
Yes.
and what you need to do if it's already down.
Exactly. After a significant event of hypoglycemia, in the same patient and the same age, do you change the definition of hypoglycemia in that patient?
No, I think we don't change the definition of hypoglycemia. I think you want to find out what caused that issue.
Yes.
Most often it might be miscounting carbohydrates, something happened, or
Yes.
activity, particularly in
Yes.
young people.
Yes.
It's going to be exercise. So
Yes.
I think we put a lot of stress on. There's lots of information available now, lots of
Yes.
research, international guidelines of how we deal with exercise.
Yes.
A very simple rule just on that piece is when you're doing exercise, before you start, you want to be above I'm converting in my head, but let's say above 140.
140, yeah? It's around 7.
About 130, 7.8, yeah. You want to be
Yeah.
above 140 when you start.
Mm-hmm.
And then you check every 20 minutes.
Yes.
And if you have an arrow, 10 grams. And if you're below 140, 10 grams.
Mm-hmm.
And if both, 20 grams.
Yes.
So if you do that every 20 minutes,
Yeah.
you're going to be fine.
Yeah.
So kind of treat that core cause. But a lot of people run sugars high if
Yes.
you're hypoglycemic. A lot of my practice is built around people with problematic hypoglycemia.
Yes.
And we've always found that the best way to sort hypo is to treat as optimally as possible.
Okay. Maybe and our question was like when you treat somebody, a 30-year-old patient
Yep.
with, like, let's say, type 2 diabetes who was on oral hypoglycemic or
Yep.
something, versus someone at the same age with on insulin therapy, versus someone who was like 75-year-old with type 2 diabetes. That's my question is like, how do you like...
Oh, for sure.
yeah.
For sure. In that scenario. And so what's really important is that we explain to our patients that all of your risk of diabetes is front-loaded. Everything is about being aggressive early on when your risk of hypoglycemia is low. You have preserved C-peptide, you're young, your brain has plasticity, so you be really aggressive under the age of 50, everything, I would argue I want to be super aggressive. I want to look at time in tight range. I want to push hard because if I do hard there, I'm going to save a lot of money and a lot of complications later on. As soon as someone clicks over 60 or 20 years of diabetes, the attitude swaps over.
Okay.
And then now you're right, absolutely. We look at frailty, we look at comorbidity, we look at awareness of hypoglycemia, and that's where I will say, okay, do you know what? Now we've done the hard work.
Yeah, the threshold should be...
Now we need to back off and make sure that my tolerance for hypoglycemia. And again, when I've got a younger patient, my tolerance for hypoglycemia is more.
Yes.
If you're having 4% hypoglycemia, but your time in range is good, I'm very happy.
Yeah.
But as soon as you go past 60, I would say no, time below range needs to be less than 1%. I still need to maximize my time in range,
Yes.
but I'm much more aggressive about stopping time below range.
Your priority changes.
Absolutely.
Yeah. So it should be like a patient customized to the patients
Customized
in
to
front of it. So if you go to speak about what are the cardiovascular outcomes of the, or the side effects of hypoglycemia, if you can go over that, please.
Yeah, for sure. So I spend a lot of time taking people to my lab, and we make people hypoglycemic.
Oh.
We bet them down to 45 milligram per deciliter for 1 hour.
Oh.
Right?
Okay.
And I say that to my patients because number one, it says that actually a single episode of 45 for 1 hour.
Yeah.
I've done at least 250 experiments like that.
Okay.
And my colleagues around me who work in this area, between us, probably 10,000 times.
Yes.
Right? So number one, people think, if my sugar's going to 40, I'm going to die. That's not the case.
Okay.
We do it all the time.
Okay.
But we've worked out what the harms are.
Yes.
And the harms are when you go down that low, below 50,
Yes.
your body makes an inflammatory reaction.
Okay.
And that inflammation, prothrombotic effect, atherogenic effect, remains for more than a week after. So actually the risks of non-severe hypoglycemia are higher in type 2 than in type 1, and they're related to the adrenaline response for hypoglycemia.
Okay.
So if you're asymptomatic, you don't have adrenaline, you don't make the inflammatory response, the cardiac risks are lower.
Yes.
But if you're type 2, you're having infrequent events, but you're very symptomatic, high adrenaline response, then the cumulative impact starts to build up.
Yes.
Right?
Yes.
And that's probably the reason why severe hypoglycemia is linked to CVD disease, right?
Okay. Yeah.
So we know that people with severe hypoglycemia, we need to be looking at those people.
Okay.
There was a lovely study from Leeds in the UK, and they looked at people admitted to hospital with severe hypoglycemia. And the average age was 72, the average glucose was 50 when people were admitted, and the mortality at 1 year was 22%.
Okay.
If you're an elderly person with comorbidities admitted to hospital with low, 20% mortality. And then they did a study where they used sensors, they intensified therapy,
Okay.
they worked closely, and randomized people to standard care, and then working with a nurse, just a nurse,
Yes.
working on that people, and they reduced that excess mortality by half
Okay.
by stopping the hypos happening again.
Okay.
And just
okay.
adjusting the insulin and kind of managing things. So that's the link. Yeah.
Yeah. So, like our clinics are usually extremely busy clinics. We have lots of, things happening at the same time. So people are coming with, you have to see the CGM, the reports, the pumps and stuff. So in a busy clinic, how do you assess the risk here? I'm sure that every patient at every visit, at least we need to have few questions that we need to ask or assess the risk of hypoglycemia. So how do you do that in the clinic?
So absolutely, we were struggling with the same issue in my hospital, and I remember someone was coming in to visit and watch my clinic.
Yes.
And he said, you know what, you start seeing the patient and you hit the patient with multiple questions. This, right?
Yeah.
And so the first 7-10 minutes of your appointment are taken in acquiring information.
Yes.
And you have no time left to explain why you're making the treatment decisions you're making,
Yes.
which is why the adherence to that treatment is low.
Yes.
So I moved a lot of my question taking to pre-clinic.
Okay.
So I developed it, it's actually free available, I developed a pre-clinic questionnaire.
Okay.
So I asked the patient, in the pre-clinic questionnaire, when the patient comes in, he has a piece of paper like that, and I look at it first. I say, okay, the first question is, what do you want to talk about?
Yeah.
The second question then is, have you had severe hypos or DKs? The third question is, what's your awareness of hypoglycemia? The fourth question is, what's your carb counting skill? The fifth question is, what's your diabetes distress? The nurse is already on the blood pressure, cholesterol, and things. So when I look at that piece of paper, within 30 seconds, I know what the risk is of that patient of hypoglycemia. The more comorbidities, the more risk.
Yep.
The more hypo awareness, the more time below range, the more risk.
Yes.
So if you can get that information pre-clinic
Yes.
in some way, and I know the health system is different here, so it's tricky, but that's how I solved it. And that gave me back that 5 or 7 minutes in which I can discuss what the most important point in that consultation.
Yeah. There are a group of patients, doctor, who are, let's say, maybe the poorly controlled, or those who are coming in recurrent DKA or something, and they start coming, starting to be more compliant to treatment, and they start getting or noticing hypoglycemia symptoms at a level of 110 and 120. So how do we deal with these patients where they really feel the symptoms of low and the blood sugar is 120?
I think that's it's a great question, and something that I think everybody really struggles with.
Yeah.
And we all will have, you will have your little technique of what you might say to people.
Yes.
Something that I try to question with them is that it's like a thermostat.
Mm-hmm.
And a bit like if you move from Emirates to UK, even a UK summer will feel like an Emirati winter, right?
Yes.
And it will take you some time to get used to it. But if you never get used to it, you're going to stay high.
Yes.
Secondly, I also maybe sometimes, if I've got the right connection with the patient, I might challenge them, because I'll say, what's the symptoms of fear? Sweating, shaking, panic. What's the symptoms of hypo? Sweating, shaking, panic. So are you actually feeling the symptoms of hypoglycemia, or are you just scared of what will happen? And if I can reassure you that if you hit 70, nothing will happen, I take people down to 40 for an hour and nothing happens to them.
Yeah.
So it's not it's not your body rejecting the sugar, it's just your emotion being scared. And if I take it one step further, for that person whose HbA1c has always been high,
Mm-hmm.
the only time they've experienced a glucose of 110 has been when they've taken a big correction,
Okay.
right? And they've been dropping.
Yes.
When you get someone that's more stable, that 110 is a stable 110,
Yes.
and it's a different scenario. So there's a few different angles that you need to work with, but predominantly it's an emotional response, not a biologic response. And you work on, so when you get in the symptoms, what are you scared of?
Okay.
I'm scared I will die,
Yeah.
but you won't.
Yes.
So where's that fear coming from?
Yeah.
It's coming from ignorance or information that's incorrect.
Yeah. Yeah.
Because what they've been told is, oh, if my sugar 70 is hypo, so what the nurse tells them is 70 is hypo, and if you have a hypo, you'll be unconscious and die.
Yeah.
And they don't separate out
Yes.
that story. So what are you feeling? I'm feeling sweaty and shaky. Yeah, that's because you're scared. What are
Yeah.
you scared of? Something that's not true.
Yes.
Does that help? Does that make sense?
Yes. Yeah. So what do you think? Like, what system changes would happen in our medical system that could reduce these things, that reduce hypoglycemia and over treatment of hypoglycemia also?
Fundamentally, and I'm sure you'll agree, it's all about trying to get more education to our patients, and that's something that we really struggle with, even in the UK, about getting people the right education. We do a lot through, so in the UK, I'm ex-chair now of an organization called Diabetes Technology Network.
Okay.
And we put out the standard education for people using CGM was the videos for these, and they were freely available. So when people come to my clinic, I'll say, look, and what you realize is that when you have 15 minutes for the appointment, the patient coming in is actually really scared. It's a bit like going to the headmaster's office. The patient knows my A1C is high. I'll see Dr. Asma, and Dr. Asma will say, your sugars are really high, you're not taking insulin, you're not checking your sugar. So I'm in the mode of listening to being told off and getting out of them. And so even when you give really nice, compassionate, nice advice, trying to really empathize with that patient, they're not in a receiving mode to get it on, which we realize, because they come back and he says, I said this last time, they said, huh? Or at the end of the consultation, I will often ask, so what have we agreed? And they'll go, blank. So I've been talking for 20 minutes and you did not understand anything.
Yes.
So we make sure that we give them the written information, and we link them to videos. We say, go and watch that stuff a bit more calmly. Everything I've just said is in these videos, and you can.
Yeah.
So I think trying to find a way to, and we're competing, aren't we? We're competing with the university WhatsApp.
Yes, it is. So, doctor, I mean, I'm sure that you deal with your population is like multicultural, same as here. Yeah. So, one of the things that we haven't now, maybe we were speaking about hypoglycemia, which happens like all of a sudden. But what we know that the patient is going into something which is hypoglycemia or by induced, like for example for exercise, or like when they are fasting in Ramadan or in other faiths where they do this type of fasting. So, what do you advise them in those where you know that the risk of hypoglycemia is much more higher? So how do you deal with these situations?
So Ramadan is a big thing. I work in Leicester, where probably 40% of the population is ethnic minority. Many of them observe Ramadan fasting. So there's been a lot of interest and work with that. And certainly what we know is that if you use a CGM
Yes.
and you adjust your insulin with advice from an expert, you can reduce the risk of having to break fast by more than 50%.
Okay.
Okay? You will drop your basal insulin, you will make sure that you're adjusting, and you've got the sensor so you know, you can watch, you know where you're going, instead of flying blind. What we know with closed loop, and there's been some lovely papers and a position statement as well around the use of closed loop in Ramadan, particularly for
Yes.
people with type 1 diabetes.
Yeah.
There, the risk of having to break fast drops down to less than 10%. Because the pump will reduce the insulin according to what you need.
Yes.
So I think the technology is hugely beneficial for people who want to follow their faith and fast.
Yeah. So this is towards the managing your insulin and to reducing. What about maybe if some dietary advice that you can give to your patients in this situation where can reduce the risk of hypoglycemia, either like maybe postpone their take the last meal maybe late just before the start of the fasting
And
and
actually,
stuff.
and a big way of doing that is paradoxically in your main meals. And this might be difficult, of course, because those main meals, when before the fast and after, tend to be high carbohydrate.
Yes.
And people often might want more carbohydrate to push their glucose higher.
Yes.
But actually, probably the evidence might say that you want it to be medium carb and higher fat.
Yes.
Because if you have a higher fat, so you have a curry, you have a cheese, you have that sort of thing.
Yes.
You can keep the sugar higher for a bit longer, and you reduce the post-meal drop.
Yes.
Afterwards. So those are probably the dietary advices that we kind of support.
Yes.
But there's some lovely position statements in the UK. So there's an organization called the South Asian Health Foundation.
Okay.
It's run by one of my mentors, Professor Kamlesh Kunti and Wazim Hanif. And they've got some great guidelines for Ramadan and that are really I would encourage people to look for.
Okay. Well, I think, Dr. Pratik, I asked you a lot of questions about hypoglycemia. Is there anything here that you would like to add about, the topic itself?
I think the main thing that I'd like our listeners to look at is that hopefully you've taken away that message of the different stages of hypoglycemia. And when we say hypoglycemia, I think we need to be clear as healthcare professionals about what we say, what we mean by hypoglycemia. And I talk about, let's say, 5 stages of hypoglycemia. You've got the prevented hypo.
Yes.
Where you took action before any activity, before you exercise, to keep your sugar stable, right? There's also the kind of a second type of prevented hypo, which is your sugar is dropping.
Yes.
And you see that, and that's like when I said you're in the middle lane of the highway, and instead of waiting for you to hit 70 and then taking a big correction, you do a small correction there to keep yourself steady.
Yes.
And then you've got the kind of alert, be careful zone at 70. The second beep, don't go lower at 55.
Yes.
And then even if you hit 40, it's fine. Treat it, get out of there. It's unpleasant. But I want people to be comfortable that thankfully all those things that you hear about the commonest thing I hear in clinic is, I'm scared about going low at night because I might die at night.
Yes.
What do the numbers say? The numbers say that it doesn't happen. It happens so rarely. And generally if it does happen, it's a combination, certainly in the West, of alcohol, exercise, and a very, very prolonged. You need to be below 40 for 2-3 hours.
Yes.
And hopefully when people are seeing experts, that's unusual. So I want to try and, my message is balancing the risk and the fear.
Yes.
And for us as doctors to be clear about, there are some people who are not scared enough of hypoglycemia, and you will see some of those people who run low a lot.
Tight control, extreme tight control.
Yes. Where the fear of hypoglycemia is lower than what it should be.
Yes.
Than the risk.
Yes.
And we see, and that's about 10% of people.
Yes.
And we see people on the other side where the fear is super high, but their risk is super low.
Yes.
And identifying that mismatch.
Yes.
And balancing it. Is a really important game kind of to understand.
That's why always we say it's the same disease, but it's never the same in the two patients. It's completely different. It's completely different. It might be that you will be, as you said, that someone who is like really in severe hypoglycemia, and then they're fine with that. That doesn't matter the control. On the other hand, where they are really at the risk of hypoglycemia and there's nothing going on.
So I had a slide that I had for many, many years, and
Yes.
I've now made it. I will show it in the talk. And I when I was here, I did a skydive,
Yeah. Okay.
and in a sense, it made me think about when you're in free fall. That is what the patient thinks like when their sugar is dropping rapidly and they're getting all the symptoms. You have that adrenergic reaction. Your heart
Yeah.
is pounding. You're sweating. You're shaking. You want it to stop.
Yes. 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 Yes.
And then, of course, you treat it and you come out of it. But in that experience, you can imagine the same experience
yes.
if you did it to 100 people.
Yes.
There'd be some people, their personality will mean that they will say, this was really fun.
Yes.
I don't mind being hypo. It's easy. I can deal with it.
Yeah.
It's fun. The skydiving analogy would be I become a professional skydiver.
Uh-huh.
And the other group says that was so scary. Even if I see a plane, I get a panic attack. Even if I
Yes.
see my sugar dropping below 100, I
Yeah.
feel scared.
Yeah. Yeah.
And this is not a feature of the stimulus,
Yes.
the skydive or the hypo.
Yes.
It's about the person it lands on and their inherent personality. And there's something about that we need to understand and bring people back to the center where
Yes.
be a little afraid of hypoglycemia,
Yeah. Yeah.
but understand that it's not gonna,
Yeah. Yeah.
it's not as dangerous as it sounds like.
100%. 100%. So, doctor, you believe that the first way to prevent hypoglycemia is education.
Absolutely.
It's education before technology, before everything. It's education. It's such an education.
And everything is additive. Everything works together, doesn't it?
Exactly.
We need to balance the fear we put in.
Yes.
So I met I met a pediatric endocrinologist, and he said I have a zero hypoglycemia policy, and actually that means that you're gonna run your kids high, and an A1C of 8.5% will drop 5 IQ points from your child by the time they're 15, right?
Yeah.
Yeah.
Yeah. Yeah.
Actually, mild, non-severe hypoglycemia has no long-term impact
Yes.
on children.
Okay.
It's unpleasant, it's scary, you have a sensor, you know where you're going.
Yeah.
You're not going to let it go below that
Yeah.
40 mark,
Yes. Yes.
and you'll
yes,
keep it
yes.
going. They have the technological awareness.
Yes.
You can be aggressive, you can push hard.
Definitely. And the guidelines are going towards lower and lower hemoglobin ANC without hypoglycemia. So that's where become the real challenges.
Well, and again, I'm going to say, with a tolerance of mild hypoglycemia, if I rephrase,
Yes.
rather than saying without which hypoglycemia? Without severe hypoglycemia.
Without. Yes.
But if you're calling hypoglycemia 70,
Yeah.
you're going to get it.
Yeah.
And we have to make people familiar and aware
Yeah.
that we can do our best to minimize those episodes.
Yeah.
And that's where technology is so
Yeah,
critical,
yeah,
right? We
yeah.
live in this amazing world here in the Emirates with these tall buildings and
Yeah,
these,
yeah.
amazing infrastructure and forward-looking thing.
Yeah, yeah.
And I think it's really important that, certainly for a child,
Yeah.
we used to say that a lot of the fear from hypoglycemia comes from the world when people. It's when you're working on finger pricks.
Yes.
It's like you're on a tightrope
Yes.
and you're blindfolded,
Yes.
and you can open your blindfold to see where you are.
Yeah.
And then you have to close the blindfold till the next finger prick.
Yes.
So you're obviously going to take the safe option.
Yes. Yes. Yes.
But with a CGM, your eyes are open now.
Yes.
You can see where you are.
Yeah.
And there's no reason why your sensor will beep when you're at
Yes.
65.
Yes. Yeah.
I never set my alarm at 70. I usually set it at 65 or 60.
Yeah.
You see when it's coming at 60, it beeps. You take your
Yeah.
10 grams of carbohydrate.
Yeah. And actually, doctor, that comes a very something point that when sometimes, there's somebody alert you that the patient is hypoglycemic 70 or who's not diabetic. I said, listen, 70 to start, it's not a low blood sugar. It's a normal blood sugar.
Yes.
But then why you say, well, because the patient is on insulin or anti-diabetic medication, which put you at the risk of hypoglycemia, we set that
These are rules.
level.
These are rules from people who did not monitor at SMBG, right?
Yeah.
So if you not have CGM,
Yes.
okay.
Yeah.
Then you 70 because you don't know if that 70 is going down or going up.
Exactly. Which direction?
With CGM,
Yes.
the alarm should be somewhere,
Yeah.
I've argued a lot in the international consensus guidelines
Yes.
that the lower end should be 63.
Yeah.
That's what the science says.
Yeah. Yeah.
Yeah, but 70 is in the it's there because of the fact that not everyone has access to CGM.
Yes.
That's the reason.
Yes, Yes, because of that. Well, Dr. Pratik, was really nice having you here at the EDEC and here in Dubai, and have a wonderful waiting for your lecture this afternoon, and hopefully to see you in the coming conferences as well.
Thank you so much for this
Thank
kind
you.
information. It was a pleasure to be here in Dubai, and congratulations on a fantastic conference and so many great speakers. Thank you.
Okay, thank you.